After a long period of online activities, we have managed to gather some of the members on campus, while most of the participants still have to join us online in order to follow the Google SOPs. I'm pleased to welcome our honorable guest speaker, Dr. Zafar Mirza, who has previously served as a state doctor in Pakistan, directed assistant development at STMU, office. He also led Pakistan's national response for the first wave of COVID-19, currently working as an advisor to the WHO on universal health coverage. So, today, Dr. Zafar Mirza is going to tell us about the concept of universal health coverage, emphasizing the role of universities in promoting global health coverage, especially in the low-resource settings. The mission will be followed by a question and answer session, primarily posting your questions in the chat box and the evaluation forms for CIE points. I would now request Dr. Zafar Mirza to please share your valuable presentation with us. Thank you.
या उसको करीब स्टाफ नहीं यहाँ से
So, even if you start understanding the concept universal health coverage, many people don't believe in it because they say, oh, it's an illusion, it's not possible, it's very difficult, it's complex, it requires a lot of resources, and we cannot afford it. तो मैंने कहा ये भी जरा मिथ जो है मैं थोड़ी सी आपके साथ इसको डीमिस्टिफाई करूं। और तीसरी वजह ये थी कि हमारी यूनिवर्सिटीज जो हैं मेडिकल यूनिवर्सिटीज या आई लाइक टू कॉल देम हेल्थ यूनिवर्सिटीज रादर देन मेडिकल यूनिवर्सिटीज, they find at odds if you ask them, okay, what is your role in advancing or promoting universal health coverage? They're not very clear. They have not thought about it generally. So I thought we will also have some discussion on this, that what possible roles academia and universities in a country like Pakistan can play in advancing and promoting and practicing the universal health coverage concept. So ये तीन वजह थी मेरे ज़हन में कि जब मैंने ये टॉपिक डिसाइड किया। ये आपका यूजुअल डिस्क्लोजर है, मेरा कन्फ्लिक्ट ऑफ इंटरेस्ट सिर्फ मेरी कमिटमेंट विद द यूनिवर्सल हेल्थ कवरेज है, नथिंग एल्स। Let me begin by saying that in post Second World War world that we have, the modern age that we call it, the concept and the notion of health has received a lot of attention, especially when the World Health Organization was established in 1948 and its constitution was put in place. For the first time, humanity actually got together and tried to explain and define the concept of health. Health भी एक ऐसी चीज है कि जिसको हम बोल जाते हैं लेकिन without really understanding it. So they try to define it, and it is the part of the preamble of the constitution of the World Health Organization. It's a very powerful concept and a very comprehensive concept. Health is a state of physical, mental, social well-being, and it is not just absence of disease. ये दो फिक्रे जो हैं अगर आप इस पे गौर करें तो ये एक पूरा it opens a new door of understanding about human health and its importance and what it involves. फिर Universal Declaration on Human Rights जब United Nations तश्कील पाई तो उन्होंने जारी किया और उसमें भी हेल्थ को एज ए ह्यूमन राइट एस्टैब्लिश किया गया। और हमारा जो WHO का कॉन्स्टिट्यूशन है उसमें न सिर्फ ये कि इसको एज ए फंडामेंटल ह्यूमन राइट की लिस्ट में इसको शामिल किया गया हेल्थ को, but it went up to an extent to say that it is the responsibility of the state to provide health care to its people and its population. These are very powerful, very important concepts, and sometimes we tend to forget them or ignore them, but I think it's very important to go back to the fundamentals if we want to talk about and understand universal health coverage. Fast forward from 1948, as we entered in the 21st century, we entered with a set of Millennium Development Goals, if you remember. And in 2015, we came up with a new set of goals, which we call Sustainable Development Goals. And Sustainable Development Agenda, I would like to call it, is such a powerful description of what it involves to actually have a sustainably developed world. It encompasses people, planet, and prosperity, and everything
which is linked for developing people, for securing planet, and for ensuring prosperity. So they came up with about 17 goals, all very interconnected. None of these goals is possible to be achieved alone. So they are all very well connected. And I think at least after a couple of months, I pull up the outcome document or the declaration which came out for sustainable development from United Nations. And I believe that all universities should make this as an essential reading for everybody to understand the world, to understand the problems of the world, and to understand that what solutions can be actually practiced in order to achieve a sustainably developed world for us and for our future coming generations. Health was positioned very centrally in this sustainable development agenda under the third SDG, which is about good health and well-being. And there are a number of targets under each one of the sustainable development goals. And the target 3.8 in SDGs is related with universal health coverage. So it was thought and it was proposed to achieve universal health coverage. And by the way, this is agenda for 15 years. So by 2030. So by 2030, world set itself to achieve universal health coverage, including financial risk protection, about which we will talk in a minute, access to equally essential healthcare, quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. When this statement came, we were a little bit not very sure that why medicines and vaccines have had to be brought. But in the COVID-19 and what is happening in this unequitable world about vaccines, I think it has qualified to be there. So this is a prelude for me to explain that what position, what importance, and what significance universal health coverage has got in the larger scheme of things of sustainable development agenda for the world, which 194 countries in the world and their heads of the states have signed, including Pakistan. So it is hardly a choice. The only option is to understand it and adopt it as a policy and implement it. Universal health coverage is understood differently by different people. But World Health Organization has come with a very comprehensive explanation of what universal health coverage is. And I think it is worth reading it. It means that all people, and it really means all people, without discrimination of any kind, on the grounds of urban, rural, black and white, fat and thin, girl and boy, rich or poor, all people, without any kind of, and I must add, political beliefs and ethnicity. Without any discrimination, all people and communities can use the 5 kinds of health services. 5 kinds: promotive, preventive, curative, rehabilitative, and palliative services. Often in our medical university settings and hospitals, we are basically talking about one kind of health services, and these are curative health services, or maybe rehabilitative, sometimes palliative, but promotive and preventive are the most ignored areas. Services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. This is very critical part of it. कि अगर आपके पास पैसे नहीं हैं तो इसका ये मतलब नहीं है कि आपको हेल्थ केयर डिनाई क्या कर दी जाए. You need to be protected financially in order to serve you as a human being for your health care. तो इस अगली पूरी जो मेरी presentation है उसमें basically I will be coming back to different parts of this definition and try to explain to you a little bit detail in the limited time and also give you a sense about how the situation is in Pakistan with regard to all those different aspects of universal health coverage. Obviously, there is a time limit, so I will speak in broad contours, broad strokes. I cannot go into too much detail, but each one of these aspects require a different webinar. आप financial protection पे एक पूरा webinar कर सकते हैं. आप quality of health services पे एक पूरा webinar कर सकते हैं. आप health services के ऊपर and the kinds of different 5 kinds of health services, each one of them require a different kind of discussion and discourse. But nevertheless, let's move on. तो सबसे पहले हम कोशिश करते हैं कि ये जो 5 तरह की सर्विसेज हैं इनकी डिटेल क्या है, लेकिन इस डेफिनेशन को समझने के लिए ये ग्राफिक बहुत हेल्पफुल है. अगर आप सोचें तो we are talking about 3 dimensions of healthcare. Number one, in the context of universal health coverage, of course, number one, we are talking about that all people. So population needs to be covered. So that is one axis of this cube, that whole population needs to be covered. Second axis of this diagram is, or this definition of universal health coverage is, that everybody need to have access to needed health care services. So needed, I said, so which means that according to the burden of disease in the country which afflict the population, the services need to be decided, that what kinds of services, in what proportion, where, at what level of healthcare will be provided to people. And gradually you expand the expanse of health services of the 5 kinds. तो एक एक्सिस इसका ये है कि वो मुस्तकिल health services की continuous review and their expansion and adding of different health services according to the burden of disease. And the third axis here is financial protection. Those who cannot pay must not be denied healthcare, because healthcare is their right and it's the responsibility of the state. And hence it is very important that we take special care of those who cannot afford. ये जो क्यूब के अंदर एक छोटा क्यूब है, ये generally represent करता है the situation at any given time in a given society. How many people are covered on x-axis, how many services are covered on y-axis, and how many people are financially protected on z-axis. So this is very important to understand that these different dimensions of universal health coverage, where we stand, what we need to do, and that will actually dictate that what kind of policies, what kind of resources, what kind of human health workforce, and what kind of health information systems and so on are required in order to expand this internal cube within the larger cube. That's what universal health coverage is in one go. अब जरा थोड़ी सी हम बात करेंगे सर्विसेज की, कि जब हम 5 तरह की सर्विसेज की बात कर रहे हैं तो उससे क्या हो रहा है, और अगर हमने सारी पॉपुलेशन को वो सर्विसेज देनी है तो वो कैसे देंगे. So this is a story of last 28 years. In 1993, this work started by World Bank when they produced their World Development Report called Investing in Health. Every year, World Bank produced one flagship report on different aspects of human development. And in 1993, first time they picked health as a subject and they produced a report investing in health. And they proposed this idea that in low and middle income countries, where always resources is a problem and resources are limited, if you want to provide health services to everybody, where you will draw the line that which services you will provide by public money, spending public money, and which services you will not provide. And you will draw a red line there. And on what basis? So how you will decide your priorities? So DCP-1, that is these disease control priorities, first edition was produced in 1993. The second edition was produced in 2006. And the last version was launched in 2017, December 2017 in London, in which these 9 volumes were launched actually. And each volume of it covers one particular area of healthcare, whether it is child health or whether it is non-communicable diseases or whether it is essential surgery or whether it is pandemics and so on and so forth. And with the help of more than 500 area experts who were engaged over more than 5 years, or 7 years, they actually indulged on the basis of the burden of disease which was in front of them in the world, as well as the best evidence which was available for the cost effectiveness of the health services. And they agreed to a set of services which are, number one, high priority health services in that area, and which are feasible to be delivered and which has proven their effectiveness. वैसे तो हजारों सर्विसेज हैं, हर तरह की चीज जो है वो हर एक को चाहिए होती है, लेकिन when governments have to decide with limited resources, they have to prioritize. This is a prioritization is the key word here. So this helped governments that if they have to allocate monies for their population and essential health care of their population, how they will prioritize that what will be provided to whom, which has maximum impact and which actually serve the maximum number of people based upon the burden of disease. I'll not go into the details, lekin 4 clusters or 21 packages were developed in which all kinds of health services belonging to all these areas were grouped together, and they were eventually synthesized into an essential health services package, which is a very important outcome of this very long exercise expanded over last 28 years, जिसमें essential health services package propose किया इन्होंने कि ये अगर 218 health services can be provided in any low and middle income country, it can take care of more than 90% of healthcare needs of the people. Very scientifically done, very rigorously done with the help of the best possible evidence and with the help of best possible experts wherever they were available in the world. इसमें ऐसे एरियाज भी फिर कवर हुए कि जो जनरली डेवलपिंग कंट्रीज में पुअर कंट्री सेटिंग्स में ये सोच के कि ये ज्यादा अहम नहीं है उसको छोड़ दिया जाता था. मिसाल के तौर पे mental health which represents a sizable burden of disease. In Pakistan, depression is 4th or 5th burden of disease in the country, but how much we are spending and how much we have prioritized mental health in our policies and in our healthcare delivery system. Things like these. साथ ही साथ इस बात का भी पूरी तरह इदराक किया गया कि health is not just the responsibility of the health sector or the ministries of health. There are a number of those determinants which, if not addressed at the same time, they will have very negative effect, even if you establish the best of the best health services in the country. For example, अगर आप साफ पानी लोगों तक नहीं पहुंचाते तो आपका अस्पताल हमेशा डायरिया ट्रीट करता रहेगा। अगर आप एयर पोल्यूशन को एड्रेस नहीं करते तो आपके हॉस्पिटल्स का ज्यादातर बजट आपको क्रॉनिक लंग डिजीजेस को ट्रीट करने में लगेगा। If you do not actually do preventive mental health, you will end up treating depressions and schizophrenias and anxieties later in the age. So a deliberate effort was made in this exercise also to list those services and those determinants which, if not addressed, will very negatively affect the health services, and we call them intersectoral interventions. For example, tobacco taxation is one such very important, essential policy intervention which needs to be made in order to discourage smoking rates, which has a very direct effect on human health. So 71 such intersectoral interventions, ये तमाम information available है dcp3.org. अगर आप इस website पे चले जाएं, ये 9 के 9 volumes वहाँ पे पड़े हैं, ये package वहाँ पे पड़ा है, and there are books on each one of the subjects there. So there is a huge, background knowledge which is available now. 71 intersectoral interventions, 281 essential health services. The combination of two, if provided in low and middle income countries, sustainably with enough resources, with well-established health services, with well-trained health workforce, you can take care of the health care of the people in that country or in that society. 5 types of services to be delivered at 5 levels of healthcare. Community level, primary healthcare level, facility level, first level healthcare, first level hospitals, tertiary level hospitals, and at population level. An integrated package consisting of health services belonging to these 5 categories, delivered in a staggered manner at these 5 levels of healthcare in a country, can actually help you to cover maximum number of people with maximum number of needed health care. अक्सर लोग confuse करते हैं between community. What is the difference between community and population level? So community level is when you knock at the household level and a lady health worker enters there and start working with the family members. Population level is when you run national campaigns on health education and health promotion and curbing tobacco and etc. etc. This is also very important to understand that in order to advance universal health coverage, every country, and especially low and middle income country, has to go through this process, use this 218 health services, look at the situation in their own country, use this as a model, do your own exercise, and actually develop your own package of health services. This is a model. This cannot be implemented as such everywhere, but it can be used as a very good foundation on which you can contextualize your own package and you can develop that. एक और जो बहुत important finding इस work की है वो ये है कि community level and primary healthcare level in any national healthcare system are the most important levels. And actually, 70% of these 218 healthcare services can be delivered at the community level and the primary healthcare level. which I actually calculated this morning while preparing for this presentation. Out of 218, 152 is 70% of those health services which can be provided if you have a functional primary healthcare system working in your country. The tragedy is that in most low income and middle income countries, it is exactly the other way around. The allocation of resources spent on tertiary healthcare by the governments is 70 to 80%. And primary healthcare gets round about 10 to 20%. Because it is not attractive. It is not in big cities. The big hospitals are very attractive, very sexy for politicians. In 5 years' time, during their political term, they can establish a hospital and show, dekhe maine kya kiya. But actually, the foundation of the healthcare lies in primary healthcare. Since, for example, in Pakistan, since we do not have a very functional, very well-organized primary healthcare, so people for primary healthcare end up in tertiary hospitals. So our outdoor patients, outdoor departments are full of people who are actually seeking primary healthcare, but they have no choice. So they either go to the private sector or they come to the big hospitals. But this is very important, to understand that how much can be delivered at a primary, which is actually much cheaper, and I'll talk about it, than to deliver services in a primary tertiary healthcare setting. पाकिस्तान में से हवाले से क्या हो रहा है? पिछले 3-4 साल में Pakistan has made a very big advance. Actually, Pakistan, and I'm very proud to say that Pakistan is the first country which has religiously adopted DCP3 to develop its own national package of essential healthcare services. And we have it. We launched it on 22nd of October last year. And it is in very thorough consultations and a very long consultation with all provinces, with all federal areas, AJK, etc., and innumerable number of meetings. Jisme health managers, doctors, specialists, clinicians, public health law, they all got together and they agreed on this package. This package now it is fully aligned with your burden of disease. Hence, it has mental health services available at every level of healthcare for the first time in Pakistan, by the way. And it has all different other preventive, promotive, rehabilitative services provided at different levels of healthcare. Available on the website of the Ministry of Health. अगर आप वहाँ पे जाएं तो वहाँ एक बटन है, उसको क्लिक करें नॉलेज हब, तो वहाँ पे ये सारी चीजें पड़ी हुई। ये हमने पिछले 2-3 साल में ये बड़ा एक आप यूं समझेंगे एक तारीखी काम किया है पाकिस्तान के अंदर। At the end, also I must tell you that this package and its development also involved costing. Each service is costed. एक शख्स को ये यानी per capita what it would cost to deliver each one of this service. Health economists की मदद से उसकी कॉस्टिंग की गई। पाकिस्तान में जब ये पैकेज बनाया गया तो जो हमने इंटरवेंशंस डिसाइड की इसमें टर्शरी लेवल की नहीं है, वो 117 हेल्थ सर्विसेज हमारा ख्याल है कि अगर पाकिस्तान में गवर्नमेंट एंड एवरीथिंग कम टुगेदर एंड वी डिलीवर दिस, वी हैव डन आवर जॉब। और डिस्ट्रिक्ट लेवल के ऊपर विच इज मोस्ट इम्पॉर्टेंट, द नंबर कम्स टू 88। और इस पूरे पैकेज की डिलीवरी के लिए पर पर्सन कॉस्ट इज $13। And this is backed up by a very rigorous economic calculus. अब आपकी जितनी पॉपुलेशन है उसे 13 से मल्टीप्लाई कर रहे हैं, that is your health budget. In Pakistan's history, never ever Pakistan's health budget has been developed according to the need. It is developed according to what we allocated last year. And what was the basis of deciding the last year? What we spent the year before. And it goes on and on and on. तो उसमें हम 0.2% जब इंक्रीज करते हैं तो बड़ी छलांगे मारते हैं कि देखें जी हमने हेल्थ बजट कितना बढ़ा दिया. There is no scientific basis. And it is not just in Pakistan. In many developing countries, this is how health allocations are made. हेल्थ सर्विसेज की कवरेज के लिए एक और कैलकुलस जो डेवलप किया गया WHO और वर्ल्ड बैंक ने मिलके 2017 में उन्होंने ये लॉन्च किया. दिस वाज UHC इंडेक्स. द आइडिया ऑफ हाउ मेनी पीपल are covered by a select group of health services picked from all those packages which I earlier mentioned. वो तकरीबन 14 या 16 ट्रेसर इंडिकेटर सर्विसेज हैं कि जिनको हम डिसाइड करते हैं और देखते हैं मुल्क में कि कितने लोगों को अवेलेबल है. तो पाकिस्तान in 2017 the UHC index, service coverage index I should say, was 40. Its range is 0 to 100. It's not percentage. 0 to 100 is the scale on which Pakistan was on 40. And sub-Saharan Africa was doing better than Pakistan, and it was 42. But over the last couple of years, we are gradually improving, and now we are 47th, according to the 2019 UHC index ranking of the world healthcare systems. और हमने ये भी एक्सरसाइज करवाई कि पाकिस्तान के डिफरेंट प्रोविंसेस के अंदर UHC कवरेज इंडेक्स क्या है, डिफरेंट फेडरल यूनिट्स के अंदर क्या है. द बेस्ट वाज इन इस्लामाबाद एंड इट वाज इन 2019 50.49. Actually very tragic. There is no other word to say. अच्छा, ये तो सर्विसेज थी जो UHC का बड़ा इंपॉर्टेंट पार्ट है. दूसरा पार्ट है फाइनेंशियल हेल्थ प्रोटेक्शन. एंड फाइनेंशियल हेल्थ प्रोटेक्शन की प्रील्यूड के तौर पे ये बताना जरूरी है कि पाकिस्तान और फॉर दैट मैटर इन मोस्ट डेवलपिंग कंट्रीज द आउट ऑफ पॉकेट एक्सपेंडिचर्स बाय पीपल आर वेरी हाई. एंड व्हाई दे आर हाई? बिकॉज पब्लिक सेक्टर healthcare is very weak. So many people actually end up for their healthcare services in the private sector. So more poor people you have and more poor people ending up in the private health sector poses a very major problem, because people don't have money, their needs have to be addressed, and they have nowhere to go. So country after country, there was a lot of evidence that poor people in developing countries either have to take loans or they have to sell their very small assets that they have to get a health care for a loved one. We call it catastrophic health expenditures. It is a catastrophe for a small family budget. Family budget, not health budget, family budget. Because big proportion of one family member, if gets admitted in a private sector hospital because that person needs admission, the whole family budget is upside down. So this is, if we are serious about universal health coverage, then we have to take care of such people. तो उसके लिए फिर गवर्नमेंट्स ने जो पॉलिसी अपनानी चाहिए वो है कि हम आउट ऑफ पॉकेट एक्सपेंडिचर्स को मिनिमाइज करें और प्री पेमेंट सिस्टम्स को इंक्रीज करें. That when a poor person end up in a hospital, they don't have to worry कि उनके पास पैसे हैं कि नहीं. और जैसा कि मैं भी आपको शो करूंगा कि पाकिस्तान has actually done very well in this area, very impressive. कौमी सेहत कार्ड, मैं जल्दी से अगला कार्ड इसके ऊपर रखता हूँ. क्योंकि ये बड़ा इंटरेस्टिंग है, ये जो मैंने अभी एनिमेट किया है इसको। पाकिस्तान में पिछली गवर्नमेंट जो थी उन्होंने ये शुरू किया, इस गवर्नमेंट ने उसको बहुत स्ट्रेंथन किया। हमने बड़ी कोशिश करके इसको डीपोलिटिसाइज किया। डीपोलिटिसाइज करने का मतलब ये है कि इस कार्ड का नाम था सेहत इंसाफ कार्ड, और प्राइम मिनिस्टर साहब को हमने कन्विंस किया इस चीज के ऊपर कि इसको हम सेहत इंसाफ कार्ड ना कहें, बिकॉज द नेक्स्ट गवर्नमेंट विल चेंज इट्स नेम। अल्लाह करे यही गवर्नमेंट हो वैसे, लेकिन अगर चेंज होती है तो इसका नाम डेफिनेटली चेंज हो जाएगा। सो इट विल क्रिएट लॉट ऑफ कंफ्यूजन। सो व्हाई डोंट वी कॉल इट नेशनल हेल्थ कार्ड? So just by doing this, we will fireball it to political influence. So it is a program which is aimed at poor and vulnerable people of Pakistan in order to have access to hospitalized healthcare, hospitalized, not for outpatient at this moment. And government will pay their premium for each one of the family, and these families, when they take their sick loved ones to the hospitals, they just need that card with them. They don't need to have money with them, and they will be catered. And this has been a humongous success in Pakistan. Very few people understand the nitty-gritty of this, how it is working, but it is working actually very well. हमारा कवरेज जो स्टेटस है इस हेल्थ इंश्योरेंस सिस्टम का, वो ये है कि बाय एंड ऑफ 2020 आवर टारगेट वाज 15 मिलियन फैमिलीज इन पाकिस्तान टू बी कवर्ड, टू बी एनरोल्ड। तो 14.3 के करीब हम कर सके। Everybody who is below poverty level, according to our data which was generated by BISP survey, Benazir Income Support Program, and which was linked with NADRA. So it is foolproof system. And these people are automatically, district after district, these families get enrolled in the system, and that's it. And they're briefed about it. It's a long story. Time doesn't permit me to give you all the details, and I'm very happy to come again and just talk about it, because this is such an important thing which is happening in Pakistan. So in Islamabad, it's a below poverty. In AJK, because of number of reasons, we gave it to all families. There is no poverty criteria, for example. And likewise in Tharparkar, we gave it to all families, not only to poor families. And along with that, we also have started covering other vulnerable populations. Poverty is not just vulnerability. There are other kinds of vulnerabilities. Disabled people, transgender people, homeless people, women, pregnant women, retired civil servants, government servants, etc., etc. So gradually, this definition and scope of vulnerability is also increasing in Pakistan, and gradually other people are coming in. KP, for example, thought that they will give it to everybody in the province, and they are doing this. पंजाब ने देखा देखी उन्होंने भी ये ऐलान कर दिया। I personally do not agree with this, because government should not be paying for those who can pay. Government should be paying only for those who cannot. So health insurance systems and social health insurance systems especially, they have a history of evolution even in Western Europe. Countries have taken centuries to evolve their system where they are today. So Pakistan is also taking steps in order to gradually refine the system according to the socio-economic strata and the burden of disease and vulnerability, etc. तो ये हमारे एनरोलमेंट, ये फैमिली एनरोलमेंट है, ये हमारे क्राइटेरिया हैं, और टारगेट ये है कि सारी पॉपुलेशन पाकिस्तान की one way or the other is covered. Whether government is paying for them or not is a different story. But since half of the population in Pakistan is poor, so at least half of the population in Pakistan will be provided financial protection through public money. And the rest of it will be co-payment systems or exclusively people paying for themselves. एक और जो बहुत important चीज इसके अंदर है वो ये है कि its coverage. So it covers actually everything that can make people to get admitted in hospitals, except 2-3 things: transplantations, dentistry, cosmetic surgery. ये वो चीजें हैं कि जिनको एक्सक्लूड किया है हमने इसमें से, क्योंकि they are very expensive and not very essential. Well, transplantation, those who need, is very essential, but these are those hard decisions which also bring bioethics into it, that how to decide where to draw a line, and in the larger interest of the population, not at the individual interest of the patients. तो ये वो नेशनल लेवल के ऊपर पॉलिसी मेकिंग की कंसिडरेशंस होती हैं कि जिनको आपको मद्देनजर रखना होता है. And people are showing a lot of satisfaction with this. Another very important aspect of this, which I must also mention, and I'll come back to that in a different way later, वो ये है कि this hospitalization services predominantly, more than 90%, are being provided by private sector hospitals. Except in KP, everywhere else, and even in KP also, the private sector hospitals are also involved, but in the rest of the country, there are around about 450 very thoroughly selected private sector hospitals, from which government is in a way buying services for the poor people. And that's what it is. So that is also a very major change, because government and ministries of health have seen and looked at private health sector only to regulate it traditionally. But this is a move from regulation, not just regulation, but also provider of services under a certain system. तो ये दो मैंने आपको चीजें एक्सप्लेन की हैं, एक सर्विसेज पार्ट कि सर्विस कवरेज यूनिवर्सल हेल्थ कवरेज में कैसे होती है, और दूसरा फाइनेंशियल प्रोटेक्शन हम कैसे दे रहे हैं और पाकिस्तान में कैसे दे रहे हैं. There are 8 macro considerations when you think about universal health coverage in any country. 1, आप प्रायोरिटाइज करें सर्विसेज को, पैकेज बनाएं अपना, बना लिया हमने. 2nd, आप फाइनेंशियल प्रोटेक्शन दें लोगों को. 3rd, प्राइमरी हेल्थ केयर के ऊपर फोकस करें. 4th, सिर्फ क्यूरेटिव सर्विसेज नहीं, integrated package of services consisting of 5 kinds of services is where our solution lies. Active collaboration करनी पड़ेगी private sector के साथ, and it will take many forms and shapes. Currently, around about 70% of healthcare is being provided by private sector in Pakistan. So you just cannot ignore, if you want to adopt a universal health coverage policy, you cannot ignore the 70% providers of the care. So you have to engage them in a strategic manner. 6th, operational digital referral system between 4 levels of healthcare. इसके बगैर आपकी universal health coverage नहीं चल सकती, because otherwise patients will be ending up at wrong levels of healthcare where they are not needed. आपको नादरा के साथ मिलके हम इस सिस्टम के ऊपर काम कर रहे हैं कि जो एक आईडी हो जो कि उनके शनाख्ती कार्ड के साथ जा रही हो, और हर एक का मेडिकल रिकॉर्ड जो है उस सिस्टम के अंदर हो, जहां भी कोई जाए, जिस भी हॉस्पिटल में, पब्लिक एंड प्राइवेट, द मेडिकल रिकॉर्ड मस्ट बी एक्सेसिबल to the doctors, to the administrators of that facility. Otherwise, this cannot work. इसके साथ साथ appropriate health workforce development in the country. आप मुझे बताएं, आप एक मेडिकल यूनिवर्सिटी में हैं, जो एक फ्रेश ग्रेजुएट है हमारा, या लेडी डॉक्टर, उनको क्या पता है पाकिस्तान की हेल्थ केयर के बारे में, हमारे इश्यूज क्या हैं, हमारा बर्डन ऑफ डिजीज क्या है, हमारी नेशनल हेल्थ पॉलिसी क्या है, सोशल हेल्थ इंश्योरेंस सिस्टम क्या है, वगैरह वगैरह वगैरह. We are training them in a different bubble, which is quite divorced from the local realities of healthcare needs in the country. This needs to be changed. The education and the training of the health workforce needs to be drastically changed if we want to move ahead with the universal health coverage. Or inbuilt system of quality assurance, safety of patients, monitoring and evaluation, etc. यूनिवर्सिटीज क्या कर सकती हैं इस सिलसिले में? मेरे ख्याल में जी 4 चीजें कर सकती हैं. एक तो मैंने अभी जिक्र किया कि medical, first of all, I think they should call themselves health universities rather than medical universities. You are responsible for health of the people, not just dealing with the diseases. It should be part of National Health Vision, and they should actively reorient their education and training programs towards national healthcare needs. अब जाहिर है कि इसमें कोई इंडिविजुअली यूनिवर्सिटी अगर चाहे भी तो बहुत आसानी से चेंजेस नहीं कर सकती. वी अंडरस्टैंड दैट देयर इज पीएमसी, देयर इज करिकुलम, ब्ला ब्ला ब्ला, बट ऑल दिस नीड्स टू बी चेंज्ड. एंड एक्चुअली आई कैन टेल यू टुडे वन ऑफ द मेजर कंसिडरेशंस ऑफ reforming PMDC was this, that we wanted to change the way doctors and the health workforce in this country is being trained by addressing their curriculums to begin with. It's not just registration of the health workforce, but it is also how they are being trained and educated in order for them to be more useful for the people of Pakistan and for their healthcare needs. सेकेंड ये है कि जो आपकी ऑलरेडी हेल्थ वर्कफोर्स है उसको भी रीओरिएंट करने की जरूरत है. और ये सारा अब होगा इन अलाइन विद योर नेशनल पैकेज ऑफ हेल्थ एसेंशियल हेल्थ केयर सर्विसेज. अगर उसमें फॉर एग्जांपल मेंटल हेल्थ दी है तो प्राइमरी हेल्थ केयर में अगर जो बंदा बैठा है या जो स्टाफ है उनको पता ही नहीं है इसको क्या करना है, तो हाउ विल यू मैनेज दिस? सो यू हैव टू रीथिंक अबाउट their knowledge base, their skill sets, their expertise, etc., etc., and you have to continue to do that. Needs-based research instead of research for the heck of it. पाकिस्तान में रिसर्च जिस तरीके से होती है आप सबको पता है, मैं उसकी डिटेल में नहीं जाना चाहता, लेकिन कितनी दफा हम कोई इशू आइडेंटिफाई करते हैं अपने सिस्टम के अंदर और फिर डायरेक्ट करते हैं अपनी रिसर्च एफर्ट उसकी तरफ. बहुत कम. आई थिंक योर ग्लोबल इंस्टीट्यूट ऑफ ह्यूमन डेवलपमेंट is one such bright example, which is parented by Human Development Research Foundation, कि जिन्होंने मेंटल हेल्थ के इश्यूज को आइडेंटिफाई किया पाकिस्तान में, उसके लिए इंटरवेंशंस बनाई, उन इंटरवेंशंस को इम्प्लीमेंट किया, अब उसे वो स्केल अप कर रहे हैं, दे आर बिकमिंग पार्ट ऑफ द नेशनल सिस्टम. दैट्स व्हाट द रोल ऑफ द यूनिवर्सिटीज शुड बी. And this is where I think universities can make a major difference. क्योंकि हमारे पास जो रिसर्च आती है वो सारी गोरों की हुई होती है. हमारी रिसर्च जो होती है वो सिर्फ पेपर छपवाने के लिए होती है और प्रमोशन लेने के लिए होती है. So this also has to be changed. And lastly, ये बड़ा एक नॉवल आइडिया है, मैं इसके ऊपर काम कर रहा था कि हमारे पास तकरीबन 120 के करीब पब्लिक प्राइवेट मेडिकल यूनिवर्सिटीज हैं पाकिस्तान के अंदर. अगर आप मैप पे उनको डॉट लगाएं उनके और उनको 10-10 किलोमीटर जो उनके इर्द गिर्द एरिया है उसकी हेल्थ केयर का रिस्पॉन्सिबल बना दें, a lot of change can come actually. They should take care of the primary health care in their vicinities. They should set up where there is none primary health care facilities. They should train their health workforce by sending them to those facilities, etc., etc. Universities cannot isolate themselves more so in developing country settings from the healthcare itself. They can't just in isolation keep educating and training workforce, half of which, if have a choice, will leave the country and never come back. So these are those revolutionary thoughts, revolutionary, although they are common sense things, which needs to be now administered and which needs to be advanced if we want to move ahead with the idea of universal health coverage in Pakistan. And we are not talking about rocket science here. These are easily understandable ideas. ये कोई बहुत बड़ी mechanics नहीं है. And countries which were worse off than Pakistan have actually done this and done this very successfully. So it's no more an illusion. Thailand, Rwanda, Brazil, Oman, Iran, Sri Lanka, South India ki states, which they have actually achieved universal health coverage for their population by practicing these ideas. पाकिस्तान मैं अक्सर कहा करता हूँ अगर न्यूक्लियर बम बना सकता है ना तो अपने सिटीजन्स को डिसेंट हेल्थ केयर भी दे सकता है. It is no more a mirage, but it is a real possibility. It's just a question of deciding that we want to do this. Thank you very much. Sorry, मैंने टाइम जरा ज़्यादा ले लिया.
Question.
जी 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 please.
Frankly, this is very good idea when you say art. But frankly speaking, from partition is speaker. Our GDP spending in health and education is minimum, unfortunately. Second part of question may
जी जी जी.
अब देखिए सर बहुत बड़ी partition, primary health and health for all, millennium development, sustainable development, they have the same basics. Still finding.
Yes, लेकिन ये जो आपने बात की है ना स्पेंडिंग की, ये पुरानी हो गई है. ये पुरानी हो गई है. मैं आपको बताता हूँ क्यों. पाकिस्तान में बड़ी तेजी से तब्दीली आ रही है. मैं आपको 3 फिगर्स देता हूँ. इसी कार्ड मैं वो स्लाइड बनाना चाह रहा था लेकिन मैंने फिर नहीं बनाई वो टाइम की वजह से. 2019-2020 पंजाब का हेल्थ बजट फॉर प्रोवाइडिंग सोशल हेल्थ इंश्योरेंस वाज 3.3 बिलियन रुपीस, 3.3 अरब. 2021 में ये बजट हो गया 23 अरब, 23 बिलियन. 21-20 में ये बजट सरप्राइज सरप्राइज इज 80 बिलियन, 80 अरब रुपए. इसलिए कि वो यूनिवर्सल हेल्थ इंश्योरेंस अब देना चाहते हैं. Resources, I have learned one thing in Pakistan. Resources is not an issue. Planning is an issue. Commitment is an issue. Policy is an issue. सारी गवर्नमेंट इस वक्त geared up है कि वो पाकिस्तान में हेल्थ केयर को इम्प्रूव करे. What we have to see, sorry, sir, what we have to see is that what role we are going to play in this. Things are going to change. ये ऐसे नहीं रह सकता जैसे है. यही फिगर्स केपी के बारे में भी हैं, इसी यानी इसी स्केल पे फेडरल गवर्नमेंट के भी हैं, इवन बलूचिस्तान गवर्नमेंट के भी हैं इस दफा. सो दीज थिंग्स आर गोइंग टू चेंज. द थिंग इज दैट वेयर वी स्टैंड with respect to ourselves as health professionals and whatever institutions we belong to, that how much we are connected with the change which is going to take place and which is actually taking place. ये मैं आपको अपने humble तजर्बे से बता रहा हूँ जो मैंने देखा है.
But in the last 2 years, COVID and other reasons, and in India,
ना सब कुछ कोर्स।
Second part, second question pertaining to yesterday there was a statement by STMU that in July
Can be.
then last week what is the reliability of the statistics and together? Thank you very much.
ठीक है जी। फोर्थ जो वेव है जी वो पॉसिबिलिटी है, इसके बारे में इससे ज्यादा नहीं कुछ कहा जा सकता। इट इज ए पॉसिबिलिटी। सो असद उमर साहब ने जो कहा है बिल्कुल ठीक कहा है, और ये पॉसिबिलिटी है, बट इसके ये बात करने का ये भी मकसद था कि अभी ग्लोबल पैंडेमिक रिसीड नहीं किया, एंड पाकिस्तान कैन नॉट आइसोलेट इटसेल्फ फ्रॉम दिस बिकॉज ऑफ ट्रैवल एंड ट्रेड। तो ये बिल्कुल पॉसिबिलिटी है, और हमें ये बात करने का ये भी मतलब है कि लोग एहतियात ना छोड़ें और हम अपने गार्ड्स नीचे ना करें, तो ये भी इसका एक मकसद है। और आपका आखिरी क्या
क्वेश्चन था?
हाँ जी बिल्कुल।
उसकी रिलायबिलिटी क्या है?
I squarely stand behind all those figures. As a former health minister, I fully support those statistics. पाकिस्तान में ये एक बड़ी इंटरेस्टिंग सक्सेस स्टोरी है एक्चुअली पाकिस्तान की, कि हमने कोविड को किस तरह रिस्पॉन्ड किया है। मैं इसलिए नहीं कह रहा कि मैं इसमें पर्सनली इन्वॉल्व था। आपके वेस्टर्न बॉर्डर्स में जो आपके कंट्रीज नेबर में हैं, आपके ईस्टर्न बॉर्डर पे जो कंट्री, मैं इटली, स्पेन और यूएस की बात नहीं कर रहा, आपके जो दाएं बाएं कंट्रीज हैं उनके अंदर जो हैवक क्रिएट हुई है, उसमें ईरान भी शामिल है, उसमें इंडिया भी शामिल है, आपने देख लिया है। पाकिस्तान अल्हम्दुलिल्लाह हैज फार्ड वेरी वेल इन दिस, इन रिस्पॉन्डिंग टू दिस, और उसकी एक बहुत बड़ी वजह ये थी, मैं इस पे आजकल लिख रहा हूँ कि अ सिंगुलर फैक्टर इफ यू आस्क मी, वो ये था कि पाकिस्तान में वी वेरी क्विकली पुट टुगेदर ए नेशनल कोऑर्डिनेशन मैकेनिज्म। NCOC इज ए ग्रेट सक्सेस स्टोरी, और उसमें जो स्टेटिस्टिक्स हैं, हमारा डिजीज सर्वेलेंस सिस्टम बहुत बुरा है पाकिस्तान के अंदर, लेकिन हमने पोलियो प्रोग्राम के ऊपर पिगी बैक किया है ये सारे स्टेटिस्टिक्स इकट्ठे करने के लिए। 28 मार्च से लेके आज तक देयर इज नॉट ए सिंगल डे कि जब तकरीबन सुबह 4 बजे पिछले 24 घंटे के स्टेटिस्टिक्स हमें अवेलेबल नहीं कर दिए जाते, एंड पीपल हैव बीन वर्किंग डे एंड नाइट। और मतलब जो डेवलपिंग कंट्रीज के अंदर हेल्थ इंफॉर्मेशन और स्टेटिस्टिक्स की सूरत हाल है वो तो किसी से छुपी हुई नहीं है, लेकिन जो हमें मिल सका और जो हमने नया सिस्टम डेवलप किया, उसकी बुनियाद पे, उस एविडेंस की बेस के ऊपर हमने रिस्पॉन्ड जनरेट किया, विच हैज शोन इट्स रिजल्ट्स। और एक और मैं बात बता दूं आपको कि कोविड-19 में चीज़ों को छुपाया नहीं जा सकता, क्योंकि डेथ्स कैन नॉट बी हिडन। Once somebody dies, that is a hardcore statistic. You cannot deny this, you cannot change this. तो उसकी बुनियाद के ऊपर हम बहुत कॉन्फिडेंट हैं कि जो हमारे स्टेटिस्टिक्स हैं वो ठीक है। नहीं, मुझे तो कोई इतराज नहीं कि किसी और ने भी शायद बोलना हो।
लोग जाते हैं अपनी के स्टेटिस्टिक्स पे बेस करते हैं, बट 60% ऑफ पॉपुलेशन वो तो
सर ये बड़ा सिंपल
है। अब इंग्लैंड every citizen twice a week.
Sir, population density is directly proportional to the spread of the disease, and population density is maximum in Karachi, so you still have maximum number of cases in Karachi, then Peshawar, then many big cities in Punjab, etc.
My name is Dr. So my question is that with the rise of digital health, what is the potential? What is this potential in provision of universal health coverage in Pakistan? It's just good Another very different question is, you talked about exclusion of certain very expensive services, like transplants and administration. Some very essential services like dialysis can somehow be incorporated for universal health.
Okay. आपका जो दूसरा वाला सवाल है उसका मैं पहले जवाब दे देता हूँ. Dialysis is included in the national health card coverage. वो तीन चीजें जो मैंने बताई उसके अलावा सब कुछ कवर्ड है उसके अंदर. वो अमेजिंग किस्म की कवरेज है उसकी. And actually people are coming from other countries to study this now. कि आप कैसे कर रहे हैं. दूसरी चीज ये है कि जो डिजिटल हेल्थ है वो ऑप्शन नहीं है. It is no more an option. It is a necessity. इसके बगैर हमारा हेल्थ केयर सिस्टम नहीं चल सकता. मैंने थोड़ा सा बताया भी था उस पर, और इस पर बड़ा काम हो रहा है. और हमने एक छोटा सा मॉडल भी क्रिएट किया था, मैनेजिंग अ बेसिक हेल्थ यूनिट डिजिटली, एंड इट वर्क वेरी वेल. और ये अब नेशनल लेवल के ऊपर हमें करना है. आज नहीं कल होगा, कल नहीं परसों होगा. काम इसके ऊपर हो रहा है और ये इंशाल्लाह जरूर होगा. जी जी.
Thank you, sir, for your valuable talk and for translation in universal pharmacology. My question is not directly related to today's topic. Nevertheless, since we are talking about universal health coverage, regarding vaccination, provision of vaccination, there is already a divide between countries. Some vaccines are acceptable in some countries and some are not acceptable for others. So, what is the position of Pakistan and especially WHO in addressing this issue? When we talk about these fundamental universal coverage possibilities and provision, and basically, I think so. Firstly, I think that this is mandate of WHO in addressing this issue. So, being WHO representative, what is your take on this?
देखिए, वैक्सीन्स की अवेलेबिलिटी या नॉन अवेलेबिलिटी का इशू इज लिंक्ड विद द inequities in health. And inequities in health exist at different levels. They exist between continents, they exist between countries, and they exist within countries. पाकिस्तान में बहुत ज़्यादा inequity है हेल्थ के अंदर, जैसा कि आपको मालूम है. So the global pandemic is imposed on a very inequitous, in a world which is, full of inequities. So these are absolutely understandable results and the situation what is happening now. Specifically speaking, Pakistan has not done very well in terms of vaccine production. We are the 5th largest internal market in the world, and we do not produce a single vaccine. Nor the government has paid enough attention to it, nor the private sector, and nor the public sector has incentivized the private sector to do that. So the situation then you end up is not very mysterious. It is very common sense that you don't produce anything, so you are reliant on imported vaccines. So imported vaccines अब जहाँ से हमें मिल रही है हम ले रहे हैं, जितनी मिल रही है हम ले रहे हैं, जिस कीमत पे मिल रही है हम ले रहे हैं, और बड़ी बड़ी महंगी भी ले रहे हैं. और ये चीज़ WHO को भी पता थी, ये चीज़ हाई इनकम कंट्रीज को भी पता थी. तो बहुत अर्ली स्टेज के ऊपर एक मैकेनिज्म इंटरनेशनली डेवलप किया गया, उसको हम कोवैक्स कहते हैं. सो कोवैक्स इज ए अरेंजमेंट, इज ए प्लेटफॉर्म developed with the collaboration between WHO and Gavi and UNICEF and one other organization. So the idea was that all vaccine which will be produced in the world will be dumped in COVAX, and COVAX will provide vaccines according to the needs of the countries. But no surprise, when you have a health emergency and when you also have resources, and when all those vaccines are also being produced in your own countries, you will not wait for COVAX. So आप सीधे अगर मैं स्वीडन हूँ तो मैं एस्ट्राजेनेका मेरे यहाँ बन रही है वैक्सीन, तो मैं कोवैक्स के पास जाने की बजाय मैं उनकी बाजू मरोड़ूंगा, उन्हें कहूँगा कि मुझे दें वैक्सीन पहले अपने लोगों को लगाने के लिए. तो ये हुआ है, यही हो रहा है. इसको एड्रेस किया जाना चाहिए, इसके लिए कोशिश हो रही है. Pakistan again was done very well in relative terms, of course. In June 2020 में, I signed those letters कि जिसमें we were in the queue in COVAX, one of the first countries, because I understood the system, WHO वगैरह, तो हम क्यू में थे और इसके बावजूद हमें बड़ी लेट मिली है वैक्सीन। और उसकी एक बहुत बड़ी वजह ये थी कि एस्ट्राजेनेका की वैक्सीन जो है, it was being produced in Serum Institute of India under contract with AstraZeneca. AstraZeneca is between Britain and Sweden. वहाँ पे जब इतने ज़्यादा केसेस होने शुरू हो गए तो इंडियन गवर्नमेंट ने कहा भूल जाओ सबको, पहले ये वैक्सीन अपने लोगों को दो। They also did the right thing. अगर हम होते हम भी यही करते। तो since we are on the receiving end, so beggars cannot be choosers, so we are, waiting for Allah to help. Or
thank you so much for a very nice presentation. For an overview of universal health service. My name is Dr. Ali and I am an assistant professor at Pharmaceutical. You mentioned the three things which were not included in universal health service. However, there are some situations where active treatment in dentistry is not there, but we have to provide some emergency procedures like patient comes to us with a very severe pain. And going through our own knowledge and understanding about dentistry, there are some emergency procedures that can be employed so that at least at that time, there and then patient can be given a relief. I'm not talking about medications, but I'm talking about some procedures like emergency opening.
मैं समझ गया आपका सवाल, सारा समझ गया।
So even those procedures are not involved in universal health.
नहीं है, they are not included, and for a very good reason they are not included. लेकिन इसका ये मतलब नहीं है, and you give me a chance to explain this a little bit. इसका ये मतलब नहीं है कि अगर वो आपके चीज़ पैकेज में शामिल नहीं है तो जिन लोगों को उन प्रोसीजर्स की ज़रूरत है, जिनको आप रेफ़र कर रहे हैं, वो उनको हम मरने देंगे, ऐसा नहीं है। और ना ये हो सकता है, ना ही एक्सेप्टेबल हो सकता है किसी सोसाइटी के लिए। तो उसके लिए गवर्नमेंट डिफरेंट फंड्स क्रिएट करती है। अभी भी ट्रांसप्लांटेशन भी बैतुल माल से हो रही है पाकिस्तान के अंदर। इस तरह के जो हैं बड़े एक्सपेंसिव, वो उसके लिए डिफरेंट अदर फाइनेंशियल मैकेनिज्म्स आर क्रिएटेड, बट the mainstream health, essential health care should not be affected with few people who need very expensive procedures. Even हमने कैंसर भी उसमें शामिल किया, आपका कार्ड कैंसर भी कवर कर रहा है। लेकिन डेफिनेटली कुछ प्रोसीजर्स इस तरह के हैं कि अगर आप एक 80 साल के बंदे का लिवर ट्रांसप्लांट करें 50 लाख रुपया लगा के, तो उस 50 लाख रुपए में आप hundreds and thousands को essential health care दे सकते हैं। These are those ethical considerations and difficult decisions that you have to make in the larger interest of the people and their healthcare needs. तो ये प्रायोरिटाइजेशन का ये जो सारा प्रोसेस है और इसके पीछे जो सारी साइंस है, उसमें ये सारी कंसिडरेशंस हैं। It's not that people are blind to it, but you have to draw lines in the larger interest of the people who are suffering from problems which require very cheap and very cost-effective interventions, जिससे उनकी जिंदगियां बदल सकती हैं। अगर आपके पास अब ये चॉइस हो कि 80 साल के बंदे को आपने लिवर ट्रांसप्लांट करना है या आपने 1 लाख बच्चे के डायरिया का ट्रीटमेंट करना है, तो आपकी चॉइस क्या होगी?
Most common maximum deaths.
जी जी
Your talk was a delight actually, a clinic delight. जिस तरह आपने समंदर पूरे दरिया को गुजरने का किया और हम सब
उर्दू बड़ी अच्छी है आपकी।
मेरा सवाल एक्चुअली आपसे ज़्यादा डीसी साहब से या डीन से है, इस लिहाज से कि व्हाट आर देयर रिफ्लेक्शंस ऑन जिस तरह दो रोल्स में, एक एज अ लीडिंग यूनिवर्सिटी इन इस्लामाबाद जो कि जस्ट नॉट मेडिकल बट यूनिवर्सिटी विद ऑल ब्रॉडर मैंडेट है, और दूसरा also as a private sector healthcare provider, leading private sector healthcare provider, because this is where the rubber meets the road. तो हम actually कर क्या सकते हैं? I would like to really listen from them कि इनके scientific reflections क्या आ सकते हैं, what can we really do?
You are being putting on the spot. And I know that you don't have a ready-made answer for this, but the point is that, let me give you a breathing space. So, point is this, that in your syndicate, the universities, especially private sector universities, the reason is that you have more flexibility, you can innovate better, and you are less bureaucratic, I hope. तो आप इन चीज़ों को relatively easily incorporate कर सकते हैं अपनी चीज़ों के अंदर. और to be honest with you, you don't have to wait for PMC and this and that. There are a number of things which still can be done in our educational systems. और चलिए मैंने आपको काफी स्पेस दी थी, अब आप बोलो.
I'll answer you. और कोई क्वेश्चन है?
ऑनलाइन दो क्वेश्चन से ऑलरेडी
ऑनलाइन कितने लोग थे?
60 प्लस थे, अब 55 है. 50 है.
So एक क्वेश्चन तो ये था कि how do you foresee the role of health universities in politics में? but एक policies of private universities
ठीक है, मैं कल ऐसे
ठीक. इस पे तो मेरा कोई बात करने की जरूरत नहीं, हो गई बात.
एक क्वेश्चन ये था कि जैसे आपने वैक्सीन्स की जो बात जो भी कोविड वैक्सीन्स की, उसकी क्वेश्चन ये कि कुछ कंट्रीज हैं जो कोई स्पेसिफिक वैक्सीन एक्सेप्ट करती हैं. So that's creating a strange kind of issue that people who are already vaccinated and vaccinated by the WHO approved recognized vaccines, they might have to be vaccinated again to travel to Saudi Arabia or somewhere. What's the role of WHO on that?
WHO has given a very clear statement, and I take this as a last question, if you agree, because now it is turning into a press conference. So, WHO has given a very clear statement on this. And this is why WHO established a mechanism to start giving approvals for the safety and efficacy of different vaccines which are being used for vaccination purposes for COVID. And the reason for that was, it was very likely and it was foreseen that in bilateral arrangements, countries will use vaccine as a tool to settle their political scores. And also, they will serve their own interests. And this has happened in every pandemic before also. SARS, MERS, influenza, H1, H5N1, इस सब में ये देख चुके. इसलिए WHO ने, and if you are interested in this, you must read 2005 IHR guidelines. In 2005, WHO and its Health Emergency Committee developed, after a very long and a very tortuous process, because countries इस पे agree नहीं करते थे. So we produced and we launched International Health Regulations 2005. वो इन सारे issues को address करती है. And what WHO is right now doing is reminding their member states कि please go back to IHR 2005 and stop this nonsense कि ये हम लोग करेंगे और ये नहीं करेंगे. आप इस पर जरा सोचें कि WHO किसी मेडिसिन को प्रूव नहीं करता नॉर्मल सर्कमस्टांसेस के अंदर. ये आपकी नेशनल रेगुलेटरी अथॉरिटीज का फंक्शन होता है. किसी वैक्सीन को वो प्रूव नहीं करता. इस केस में उन्होंने ये शुरू किया है और इसीलिए किया है कि उनको पता था कि ये प्रॉब्लम्स होंगे. प्रोटेक्शनिज्म is practiced by countries. Trade is affected with this. Politics is affected with this. So for all these reasons, अब मैं देखिए ना, मैं खुल के बात करता हूँ, सऊदी अरब साइनोफार्म को नहीं मान रहा, क्यों नहीं मान रहा? सोचने की बात है, क्यों नहीं मान रहा? वो वैक्सीन गलत है या पाकिस्तान ने गलत लगाई है या 20 दूसरे मुल्कों ने अपने लोगों को गलत लगाई है, क्यों नहीं मान रहा सऊदी अरेबिया? So I leave it to your imagination कि क्यों नहीं मान रहा?
Thank you very much.
Okay. जी? Sir, sorry again. अच्छा.
और हमारे जो हेल्थ केयर सिस्टम है उसको बड़ा बढ़ रहा है, स्पेशली जो सर्विस सिस्टम है बहुत से पेशेंट हैं कि वो वेंटिलेटर में जाते हैं की वजह से ज्यादा से बहुत कोविड के आने के बाद अगेन जो रेस्पिरेटरी सिस्टम के पेशेंट हैं वो ज्यादा बढ़ गए क्योंकि वेंटिलेटर पे बहुत ज्यादा जा रहा है जो मेन बर्डन है कैसे तो पॉलिसी लेकर है दवा यूजर है वो पॉलिसी बनाते हैं एटलीस्ट जो प्रिवेंटेबल डिजीज है जैसे स्मोकिंग है वो टोटली खत्म कर दी है वाइल पैसा स्टैटिस्टिक लाइक स्मोकिंग है वो टोटली
जी बिल्कुल, आपका बात बिल्कुल सही है और मैंने पार्टली इसको आंसर भी किया है कि अब ये सारी जो हेल्थ सर्विसेज हैं दे आर पार्ट ऑफ आवर हेल्थ एसेंशियल हेल्थ सर्विस पैकेज एंड ये नहीं है कि गवर्नमेंट पहले नहीं कर रही थी, लेकिन अब ज़्यादा इफेक्टिवनेस के साथ ये करेंगे और करने की ज़रूरत है। और एक्चुअली वैक्सीन्स की अभी हम बात कर रहे थे, आपने प्रिवेंशन की बात की है, तो वैक्सीन इज इन पब्लिक हेल्थ इज कंसिडर्ड एज द मोस्ट चीप एंड द मोस्ट इफेक्टिव इंटरवेंशन फॉर हेल्थ, क्योंकि ये आपको बहुत सारी रिलेटेड डिजीजेस से बचा लेती है कि जिनके लिए आप हेल्थ केयर को बहुत कॉस्ट पड़ती है। तो ये इकोनॉमिक सेंस भी है इसके अंदर बहुत ज़्यादा, प्रिवेंशन वर्सेस क्यूरेटिव। तो डेफिनेटली आई कांट एग्री मोर विद यू, ये करना चाहिए और जितना होना चाहिए उतना नहीं हो रहा, लेकिन पहले से ज़्यादा हो रहा है। ओके।
मेरा टेक होम मैसेज यही है कि यूनिवर्सिटी मेडिकल हेल्थ यूनिवर्सिटी
Thank you so much, sir, for an enlightening talk. We appreciate the insight provided by you, and we look forward to have you again, inshallah. I would now request the Vice Chancellor, Professor Muhammad Iqbal Khan, for his concluding remarks.
Thank you. First of all, I thank Dr. Zafar Mirza for sparing your valuable time from very busy schedule for coming and addressing this august gathering. You actually address the deans, these HODs, the principal, the senior professors, and the senior faculty of Shifa University, not only in medical science and dental sciences, but pharmaceutical sciences, rehabilitation sciences, and social sciences as well. We are grateful, sir. Thank you very much for the very thought-provoking and very enlightening talk. I just want to, for the information, you all might be knowing about that, for the information of everyone, that Dr. Zafar Mirza is the architect of present COVID preventive and management system in Pakistan. We talk about the national system, a core system, and I discussed it with him before in a meeting, that how we could be able to perform better in the other countries. Just next to us is the Iran, probably having more per capita income than us. Probably they are spending more on health than us. And India, probably technologically more advanced than us, they are producing vaccine and we are not producing. Still, alhamdulillah, alhamdulillah, we are managing better than many countries. And we appreciate your spirit, your zeal, interest, and your initiatives in developing a system which actually save our nation from this pandemic. So, and the evil effects of this, which we might be. And thank you very much, sir. Is to included in the holistic definition of health. I will request you, as we are working in WHO still, you can introduce the, apart from physical, mental, and social well-being, probably spiritual well-being is an important part that has been included in this. Okay. Regarding the questions of Usman is the assistant professor of Shifa University, and he is heading the one of our prestigious research institutions. And we invite you all to go to Madra and see this and visit this institution, and you will be enlightened at least that these people are working at the grassroots level. And I expect the more people will be the part of that as well. What university is doing? I just want to give you a glimpse of what we have been doing. We are covering, first of all, the dental services, affordable dental services for the destitute and the poor as well. So, alhamdulillah. And we are also covering the transplant services for the poor and destitute as well. So, 54 renal transplant has been conducted free of cost in this institution, and with the, alhamdulillah, very good quality. And to my knowledge, there are 18 liver transplant has been conducted. One liver transplant costs nearly 5 million rupees to the institution. And at the same time, this is the only institution in Pakistan which developed very early for the last 5 to 6 years. Alhamdulillah, we have been progress. Over 1,000 transplant has been, liver transplant has been done in single institution with a very good quality, alhamdulillah, and very ethical domains. So therefore, and they have, this is the source of inspiration for other institutions. And another institute in Lahore, they started liver transplantation and kidney transplantation because of our help. The people were trained in this institution, and then they went to PKLI and they are performing well. And these are the only, in my knowledge, these are the only 2 institutions in Pakistan providing this holistic transplant service. And this is the only institution where the multi-organ transplantation is going on at Shifa International Hospital. As far as your question is concerned, we are integrated with the hospital. And when we see 2,000 patients in a day in our outpatient department per day, we see about 500 patients free of cost as well at the same time, with the same quality and the same quality sitting here, providing the private services to the private people. The similar indoor and outdoor facilities, they provide the same services to those people as well. So this is one contribution of our university. And the university, I was just looking at the budget yesterday. University is spending 230 millions in a year in average on the provision of affordable services to everyone. One is more suggestion for the government, as you are still in the corridors of the government and the state, you can introduce an affordable healthcare services to everyone. Those who can afford, they can pay, and those who cannot afford, this has been introduced in this small institution. And you can take the example of Shifa, Shifa International Hospital, that we have made that those who can pay, they can pay for their services. Those who can't pay, they can pay. If those who can pay less, they can pay for the drugs, for the medication or the disposable. And those who cannot pay anything, still they cannot be denied of the services, even in this place. So we are not government, we are not getting a single penny from any government exchequer. We do not have any access to HSC funds or to the health ministry's fund, but still, alhamdulillah, we are providing sizable, contributing sizable, not only at the tertiary care level, but talk about the primary healthcare. This is the only institution in the north of Pakistan where the family health, which we were talking about, to convert the GPs from GPs to family medicine, we have established the Department of Family Medicine here. And the exact examination in this place is, in this institution, will be on 3 subjects, the surgery, medicine, and family health. And the rest will be covered in the other 4 years. We have a true concept of integration. Integration with the economics, with the social sciences, behavior of the people, and so on and so forth. And therefore, this institution is a base, at least in the north of Pakistan, is the base for the holistic concept of integration, where we are integrated not only among the subjects or among the different disciplines of the healthcare, but in the social integration, the integration in the economics, integration in law and other specialties as well. And therefore, our university is not a healthcare university only. It is a general university with the special focus on the healthcare. So with this, I thank you all and everyone who are here. And I'm proud to announce this morning, still it is a morning, I think. Yes, this morning that Dr. Zafar Mirza has agreed to join this university and join hands with us to establish the most effective and the most reliable as well as the affordable educational institution for the public. And inshallah, from today onward, we have the honor and privilege to appoint Dr. Zafar Mirza as Honorary Professor of Population and Public Health Practice in Shifa University. You are welcome, sir. With this, I hope that now our vice, though Dr. Mirza is not fully aware what university is doing, we have little bit different domains. We have a primary healthcare unit as well. It's not only we see primary patients are primary healthcare here. We have a primary healthcare unit in Nurpur Shah, and we established one in Mandra, and in third one, inshallah, coming. We had an idea to start with IA, this area, as to make it an exemplary unit in Pakistan to provide the universal health coverage to this area. Start from here, run as a pilot project, and Professor Zaid is working on that. And inshallah, with the help of community medicine and family medicine, and probably the hospital are very keen in that as well. So we will start from I-8 area and make an example. So without the help of the government, without the help of any other agency, we can run this institution and provide the health coverage from the birth of the child to the grave. We have graveyard as so inshallah, this is our dream. Inshallah, we are working on that, and with your help, inshallah, we will be able to ultimately establish, which is our dream, to establish an institute of public health, inshallah. And our task will be in next probably a year or 2 times, inshallah, we will develop the public health at this place. And we strongly believe that you cannot spend, अगर पीछे से आगे से टैप खुला हुआ जिससे मर्जी पानी डालते रहे वो ज़ाहिर होता रहेगा. हमारी disease burden इसलिए बढ़ता जा रहा है कि we don't have the proper preventive process in the society. As he said in his talk, कि अगर पानी गंदा है, environment गंदी है, तो आप डायरिया को कितने ट्रीट करते रहेंगे? आपके पास enormous resources, आप transplant का देखें. In Pakistan, there are 2.2 million people waiting for transplant, and this is being added every year. But every year, this number is increasing. You can. मैं अफ्रीका जाता रहता हूँ तो वहाँ पे एक डिजीज है VVF probably ज़ाइगोजेनिक फिस्टुला. तो I went to Sudan. तो मैंने वो बशीर साहब जो पहले थे उनसे मिला. मैंने उनसे कहा कि ये काम इस तरह खत्म नहीं होगा. आप हर साल वो 3,400 इंक्रीज कर देते हैं और हर साल आप 1,000 ट्रीट कर देते हैं. तो आप 1,000 ट्रीट करते हैं, 3400 उसके अंदर जो है ना इजाफा कर देते हैं. तो यही पाकिस्तान में भी कुछ इस तरह से हो रहा है. लोग ये अल्हम्दुलिल्लाह, ये जो हमारा लेडी है बेनजीर भुट्टो का एक बड़ा कारनामा है कि उन्होंने ये जो देहातों के अंदर ये जो पता नहीं क्या कहते हैं उसको, बर्थ अटेंडेंट्स को ट्रेन करने का, ये इनको ट्रेन हेल्थ वर्कर का उन्होंने सिस्टम शुरू किया था। और एक बात जो उनका एक मैं समझता हूँ कि पाकिस्तान के उसने बहुत सारी चेंज लाई है कि we went to the doorstep and we could be able to cover the peripheral area with this. तो जब तक हम ये नहीं करेंगे उस वक्त तक हमारा डिजीज बर्डन बढ़ता रहेगा। और शिफा अमीर यूनिवर्सिटी, शिफा इंटरनेशनल हॉस्पिटल एंड शिफा फैमिली इज अ पार्ट ऑफ नेशनल सर्विसेज। वी आर वन ऑफ द 6 नॉट फॉर प्रॉफिट यूनिवर्सिटीज इन पाकिस्तान। आपको भी हैरत होगी कि about 182 universities and degree awarding institutions. There are only 6 institutions के जो not for profit हैं, और वेस्ट बड़ी बड़ी यूनिवर्सिटीज हैं जिसमें ऑक्सफोर्ड है, कैम्ब्रिज है और हार्वर्ड वगैरह, ये सारी नॉट फॉर प्रॉफिट, ये नॉट द स्टेट यूनिवर्सिटीज। तो इंशाल्लाह विद दिस लिटिल बिट इनिशिएटिव्स में भी कतरा होगा है किसी उस समुंदर के अंदर, लेकिन इंशाल्लाह दिस विल मेक सम चेंज। थैंक यू वेरी मच। हैव आई आंसर्ड योर क्वेश्चन?
Yes, sir. One of the reasons I asked that question was the unique opportunity that we have Professor of Surgery, Professor of Medicine, Professor of Gynae, Professor of Community Medicine, Dr. Zafar yourself, everyone there. And as Dr. Zafar alluded to, going forward, जो model sustainable और scalable healthcare का universal health coverage का भी होगा, और ये हमारे पास एक opportunity है as a university को करने की। So I really look forward, मैं just sensitize करना चाहता था अपने तमाम faculty को इस हवाले से कि now that Dr. Zafar is going to be part of our faculty and is going to be leading it from the front, and with his expertise and insights into the process, we look forward to actually reaching out to all the faculty to actually make sure कि जिस तरह का model इसकी theoretical strong basis है with the university platform, इंशाल्लाह हम इसको on ground implement और इसको scalable model demonstrate कर देते हैं how we can do it. So thank you, sir.
Thank you very much. बहुत शुक्रिया।
Thank you.
Thank you, sir. I would now request Professor Mohammad Iqbal Khan and Dr. Mohammad Ahmed to present a souvenir to our honorable guests.
Sure. Thank you. It's very kind of you.
Professor of Surgery, Health Sciences and Principal of Shifa Medicine, to kindly conclude with the prayers.
Thank you, sir. We always try to finish all our discussions and all our meetings with hustle, because that is something which denotes and which gives a very good direction to all the conclusions and all the introductions. Bismillahir Rahmanir Rahim wal Asr. That's why Allah Mia has sworn it, saying it, कसम खा के कहते हैं कि ज़माने की कसम, इन्नल इंसान लफी खुस्र। कोई शख्स ये नहीं कह सकता कि वो बहुत ऊपर चला गया कि सारे के सारे इंसान खसारे में, unless what it is saying, वल अस्र इन्नल इंसान लफी खुस्र इल्ला अल्लज़ीना आमनू। लेकिन ये कंडीशन है उस खसारे से बचने के लिए कि पहले ईमान लेके, मतलब whatever you are doing, believe in that, इल्ला अल्लज़ीना आमनू व अमिलुस सालिहात। तो नेक अमल का मतलब ये है कि you do your deeds according to what you believe and do the right things in the right direction. إِلَّا الَّذِينَ آمَنُوا وَعَمِلُوا الصَّالِحَاتِ وَتَوَاصَوْا بِالْحَقِّ. So what you believe, try to propagate that, because you think that's the most appropriate and the right thing. So وَتَوَاصَوْا بِالْحَقِّ and وَتَوَاصَوْا بِالصَّبْرِ. So you teach and you train each other, including yourself, that patience has to be there to achieve some goals. So these are the beautiful, meanings of the Surah Al-Asr, which we always try to recite, and we educate each other and we try to convince each other, and that's how the teamwork and the community work and the leaders work that carries on and shapes and reshapes and changes the world. So Sadaqallahu al-Azim. Jazakallah.